Our topic today is the implant planning using the CBCT. The first half of the lecture, in about 30 to 40 minutes, I will be your speaker. My name is Dr. Khalid Ekram, and the rest of the lecture will be Dr. Amr Ekram, my colleague. He's going to also continue the lecture. First, these are the objectives of our lecture: is to give a brief idea about the CBCT and demonstrate the CBCT protocol for implant cases, and illustrate the steps of treatment planning for implant cases, in addition to illustration of the value of the information gained from the CBCT. Implant cases, like any dental case, needs a case history and clinical examination and radiographic examination. And sometimes we need some other lab investigations to check for some systemic conditions. Our topic mainly today is about radiographic evaluation, and especially the CBCT machine. First, the CBCT is the pioneer modality for implant cases because it gives the 3 dimensions in one-to-one correspondence. And the CBCT actually is considered like the third eye of the implantologist. For this reason, it became a basic diagnostic tool for implant cases. CBCT also is incorporated in many procedures in the process of digital dentistry. This means that CBCT can be integrated with CAD/CAM or with photography or facial scanning. A lot of techniques can be cooperated with or incorporated with CBCT. CBCT as a machine, it's a machine. It's like a capture or acquisition equipment. Also integrated with the CBCT, third-party software. The third-party software is the one that we use to display and manipulate the images and make our treatment planning. So the question is, how important is the CBCT for implantologists? Or in other words, if you are having like an imaging center, how much is the percent of referrals are coming for you for the sake of implant analysis? Actually, 65% of cases referred for CBCT is for making implant site analysis, while 35% is shared by all the other purposes, like for checking for impacted teeth or root canal treated tooth or orthodontic reasons or whatever, and perio and all of this stuff. So CBCT is very important for implant cases, and we are going to demonstrate now the applications of CBCT in our lecture today. So as I mentioned in the beginning, the most powerful value of CBCT is that it gives 3 dimensions in one-to-one correspondence. So what is the value of having the data of the patient in 3 dimensions? So I'm going to check here if we have this house and we are seeing it from front view. And this is the only view that you are going to check this house from. So you will have an imagination about this house size, certain imagination, like you are seeing it right now. But if you get another view, and if you go from the side of this house to check a side view, you will find something which is totally different than what you got from the first image alone. Similar here, we can check some cases in brief to show you the value of the CBCT. In this case, there is an implant inserted in replacing the missing upper left premolar, and on the panoramic view it seems to be in a good position. when we see the 3D image for this case, we will find that there is a buccal perforation. So the panoramic image didn't show us this perforation when used alone. We must see the third dimension, which is the buccolingual dimension. This is the second case. We're going to see something different. This is a panoramic image, and we can see here there is an implant in the lower left premolar region, and it seems to be injuring the inferior alveolar canal. So when we take a cross-section to see this canal and the implant to check it from the buccolingual dimension, we can see here that the implant did not injure the mental foramen or the nerve, although it's not in a good position, but at the end of the day, what we got from the panoramic image is totally different than what's happening in reality. What are the imaging tools or radiographic tools that we have here in order to examine or study an implant case? First, we have acquisition tools. Acquisition tools, which means the equipment that collect the data of the patient from a capture. So we have here the CBCT scans and the digital impressions, and sometimes we use the digital cameras. Those are all acquisition tools. Second is the display tools, or what we can say the softwares that used to display the data captured from the acquisition equipments. This idea is very clear here. So what I'm saying that, for example, if you have a camera and you are taking a shoot for a certain picture, you import this data to the software like Adobe Photoshop, for example, and Adobe Photoshop displays the data that I captured with the camera on the computer. And this data has a format. This format is called JPG. Similar here, we have a CBCT machine. When it captures a patient, this capture is imported to the software, a third-party software, and this third-party software shows the data of the patient. But here it is in DICOM format. I'm going to speak in details about this DICOM format. So, in brief, the CBCT is an acquisition unit. It is responsible about the accuracy of the data of the patient. What we see on the computer is the function of the third-party software. We have a lot of third-party softwares for implant planning and for imaging in general. So here we have the CBCT machine collects the bone data of the patient. We have here the optical scanners, whether extraoral or intraoral, collects the surface data of the patient in STL. And we have, of course, the digital cameras, whether 2D or 3D, collects the photo or the contour of the facial structures. So let's speak about the acquisition of the DICOM data, how the DICOM data of the patient is acquired. Here we have the CBCT machine is rotating 360 degrees around the patient's head, and you can see here this is the acquisition is made. It's in a pulsed exposure, not a continuous exposure. So what happens here, that each pulse is recorded as an image similar to the 2D image. We have here multiple captures or pulses collected. Each pulse or each image capture of these is translated in the computer as multiple files. Each file of those is called DICOM file, and this group of DICOM files is called DICOM dataset. So what's important about this? When you are having a software, an implant planning software, you must import these DICOM files to the computer in order to be able to read the case and to start working on it. So it's very important when you use any software is to know where the DICOM data is. These DICOM data inside the software is collected, all of them together. See, like this, in order to form the CBCT data that we see it displayed on the computer. After acquiring the image and having the DICOM dataset complete, now it's the turn to interpret and display this CBCT data or the CBCT scan on the software. I'm going to pass on this quickly. On the software, you will find like a group of cuts. Here we have in the screen the axial, the coronal, and sagittal. So we're going to see here a group of lines. I wanted to focus on this horizontal line. This horizontal line here is present similarly there. This horizontal line detects or shows what is the axial cut representing. So as if we are cutting from here and checking the 3D image from there. So the location of these lines shows us from where we see the image. You can consider it like a knife that you are cutting inside the bone, and after cutting it, you are checking from inside. This is exactly how we read the CBCT. As I mentioned in the beginning, in dentistry, we use other cuts. Here we must draw on the axial cut something what we call the arch curve. This arch curve is like a custom cut, as if you are getting a knife and cutting this area like this and checking from front here. What you will see an image similar to the panoramic that we are all familiar with, but it's called reformatted panoramic view. It shows the mesodistal dimension of the bone and the teeth of the patient. So here again, here the arch curve is drawn, and this arch curve will give us the reformatted panoramic. Let's stay here for a while. The arch curve should be drawn such as it's passing through the center of the teeth, and in the anterior region to be little bit buccally in order to give us a good reformatted panoramic image. Because after getting the correct panoramic image, there is a series of cuts are generated perpendicular to the arch curve, which is called the cross-sectional cut. The cross-sectional cut, it shows the buccal and the lingual dimensions of bone as well as the vertical dimension of bone. And from this cut, we get the buccolingual dimension as well as the vertical dimension. And we choose this cut to see the vertical dimension, not the reformatted panoramic. Why? Because we can see here the anatomy of the bone clearly, including any undercuts or any unexpected constrictions. Therefore, this cut is used to check for the buccolingual and the vertical dimensions. We'll discuss this in details now. Okay, what are the information that we can get from the CBCT? Of course, we can get it inside the software that we are using. I got a couple of questions before I start the presentation about what is the best software to be used. I will answer this questions after the presentation of Dr. Amr. We will answer all the questions that we will get here. So, the information provided by the CBCT, number one, which is the bone quantity and the bone quality, and the bone anatomy, as well as the relation of bone to the surrounding vital structures. My presentation will include only the bone quantity. The next lecture for Dr. Amr will the bone quality and the vital structures will be discussed in the second lecture. The bone quantity, for any implant case, we need to check the bone quantity from 3 dimensions, which are the vertical dimension, the medial-distal dimension, and the buccolingual dimension. So, which dimension should we start with? Now I need to get information from 3 perspectives. The first dimension I start to examine is the buccolingual dimension. The buccolingual dimension determines the maximum diameter that can be used as an implant size. At least 1 millimeter from each side of the implant should be covered with bone. For example, here we have a measurement of 7.4 millimeters. This means that the maximum implant diameter that I can use is 5.4 millimeter, because at least I should have 1 millimeter of bone buccal to the implant and 1 millimeter lingual to the implant. What would if we have more? If we have more than 1 millimeter here and there, what we have 3, for example, or 4? We always tend to leave more buccal bone in relation to the implant, because the buccal bone, especially in the anterior area, is very thin and liable for more resorption. For this reason, we leave this amount of bone more in the buccal side. In addition, also that the buccal side in the anteriors, it's in the aesthetic zone. So to avoid the risk of metal display, we always try to keep the buccal bone as thick as possible. Second dimension that we have here is the vertical dimension. The vertical dimension of the bone determines the maximum implant length that can be chosen. So we leave 2 millimeter safety margin from the bottom of the implant to the vital structure if the vital structure contains a nerve, like the mental foramen, the inferior canal. So you always leave 2 millimeter, at least 2 millimeter from the nerve. What about the maxilla or any bone cavity? We leave from 0 to 1 millimeter from the cortex of the maxillary sinus and the nasal floor. So here we can check the vertical dimension. So this height is 13.1 millimeter, which means that I can put a maximum of 11 millimeter implant length. But in this cut, we can see that the crest of the ridge is broad, that you can get use of the whole length of the bone, because the top of the ridge or the crest of the ridge is wide. Therefore, I can get benefit to rest the implant bed on this alveolar crest. In some cases, like here, for example, the alveolar ridge is very, very thin. And you can see the crest here is showing 3.1 millimeter, which is very narrow. To receive an implant in a straightforward maneuver. Here maybe you will need some bone grafting or bone expansion or whatever technique gonna be used. So Here I cannot get use of all the length of the bone from the crest of the ridge to the inferior canal. So what we do here, we can take the measurement below the alveolar crest by 2 millimeters, for example, here, and we will plan our case such that we will rest the implant bed on this measurement. After 2 millimeters, it will be like submerged 2 millimeters from the alveolar crest. So here I get more dimension, which is 5.2 millimeters, but you can see here the length of bone available become less by 2 millimeters, becomes 10.6. Therefore, the maximum implant length I can use here is, we can say 8.5, for example, 8.5 millimeters. So what we care about here, not the length of bone. We care about the length of bone that is gonna be useful for us, or gonna be taken benefit from, and this is called effective vertical bone height. This is our main concern. So this is to say that for each implant case there is a method to examine it. We don't have like one strict rule to see implant cases. Each case has its own maneuvers and all its own calculations. Here in this case, what if we have an immediate post-extraction insertion of implant? This means that you have extracted a tooth and then put the implant in the same visit. Here we should have at least like 2 to 4 millimeters of bone between, or sometimes up to 5 millimeters of bone from the apex of the socket of the extracted tooth and the implant apex, because the implant must get this distance in order to be properly engaged in the bone to have initial stability. So for this reason, we care also about not the length as a length. We care about the bone which is going to be beneficial in our treatment planning. The last dimension, which is the mesodistal dimension. The mesodistal dimension determines the number and diameter of the implants. There should be 1.5 to 2 millimeters between an implant and the natural tooth, and 3 millimeters in case we are planning to put 2 adjacent implants. But this rule is not strict, because at the end we are planning our case based on a lot of things. So in the imaging softwares or the implant planning softwares, there is a maneuver called implant simulation. This implant simulation that you can place imaginary implants, and we can see the distance between them. Is it possible to implant here or no? Is it possible to make like a prosthetic planning suitable with this case or no? So I'm not strict with these numbers, because, for example, if I have 2 neighboring premolars, the distance between them is going to be different than 2 neighboring molars. or a molar next to a premolar. All of these cases, each case has its own agenda. Okay, now there is something very important which is called localization of the implant site. And we need this localization especially in long edentulous span or full arch cases. For example, here I have this patient is totally edentulous. This is clinically the patient is totally edentulous. And this is the CBCT. For example, if I want to put an implant in this area, in the canine area, for example, so I can see that, okay, maybe this area in the patient's mouth is corresponding to this area for the CBCT of the patient. The problem is I have to answer this question. Are you sure that these two sites are similar? Are you sure that the measurement that you will take here is applicable or reveals the anatomy of this part of the patient's mouth? Of course not. So I have to make a correlation between the clinical implant site to the radiographic implant site. So this correlation may be made manually using a radiographic stent or digitally by what we call digital wax-up. I'm going to explain both methods. First, manual localization of the implant site. In this method, we use a radiographic stent or the patient's denture, and we place like a radiopic marker like gutta-perca points or metal balls or composite. And we tell the patient to wear it, to have the CBCT while this appliance is in his mouth. Therefore, when I have the CBCT of the patient, I am sure here that this gutta-perca, for example, corresponds to this image. And when I got the cross-sectional cut on this gutta-perca point, I can see the morphology or the shape of the bone at this site. Therefore, I could correlate between the gutta-perca point in the patient's mouth and on the CT scan. Now I can take my measurements here, and I'm sure that if I use this stent during the surgery, it will exactly allow me to drill in this clinical site that I have determined. See here we can place this same stent and we drill through this positioning stent. So when it is used here during the CBCT scan, it's called radiographic stent. When it is used inside the patient's mouth while doing the surgery, it's called positioning stent. It's just a positioning device, does not control the direction or the depth of drilling. Only it determines the position of the implant or the location of the implant. Second method is digital localization of the implant site. Here it involves incorporation of the CBCT of the patient with the surface scan of the patient's mouth or the patient's model. Here, the first step we have is to scan the patient's model with a desktop scanner or an intraoral scanner and make on the computer digital wax-up. It will be made based on the adjacent as well as the opposing teeth. So here I determine exactly the location that I want to put an implant in it. Then I have the CBCT of the patient. Then using the implant planning software, I integrate or I make superimposition between the CBCT and the surface scan using similar corresponding points. Now the digital impression together with the digital wax-up are correlated with the CBCT. And now I'm able to make my implant planning or implant simulation based on this wax-up. So after that, the lab will prepare like a similar stent based on the wax-up that he did. Maybe he can 3D print it or something, and the similar procedure can be done, or we can complete the whole case digitally by making computer-guided surgical stent. There are some important considerations during CBCT scanning. First point to be considered, which is the field of view to be used during scanning of the patient. There is a lot of fields of view to be used. Actually, what raise or drop the price of any CBCT machine is the field of view. The bigger the field of view, the more expensive will be the machine. So as an implantologist, what do you need in your office? This is a very important thing. Or if you don't have a CBCT and don't have the plan to have a CBCT, what field of view you should ask for? Well, you want to scan a single tooth, a quadrant, or both jaws, the whole skull? Let's see. So the X-ray beam can be collimated just to cover the area to be examined. When considering the field of view, it's very important that we use a limited FOV as much as possible. Why? Because if you expose areas which are not required for implants, like an area containing denture sites with restorations and this stuff, it will make added artifacts. You will have two types of artifacts. You can have noise, which is coming from natural teeth, called image noise from the scattered beam from natural teeth, or you can have metal artifacts coming from neighboring metal structure like implants, like crown fused to metal, or whatever metal is there. So we try to limit the field of view in order to increase the resolution of the image, because I don't want to go very deep into physics, but when you decrease the area to be scanned, automatically the voxel size or the resolution becomes better. So we try to use as minimum FOV as possible. Second is to reduce the risk of metal artifacts. I'm gonna later, after this point, we're gonna go to the metal artifact issue. So we have here field of view simple or made for single tooth, and commercially called endomode. It's commercially called endomode. This is 5 by 5 centimeter or less, and it allows us only to see single implant or maximum 2 adjacent implants. So if you have only one implant, this can be enough. Then you can scan half of a jaw, which is the single quadrant. You can scan a single quadrant, and this dimension is like 5 by 7 centimeter or more. And by the way, the field of view is always represented by 2 digits. The smaller digit represents the vertical dimension, and the bigger digit represents the diameter of the field of view. So always, whether who comes before who, the smaller digit represents the vertical dimension. Then a single arch, and I mean single arch is only the tooth-bearing area. I'm not considering here the third molar, because it's not commonly to be used as an implant site. For single arch, 6 by 8 centimeter or more may be okay for scanning a single arch, especially the maxilla. The fourth type is the both jaws, or what we call inter-arch. This shows both jaws, but only the teeth-bearing area. It's not used for maxillofacial. And this can be 8 by 12 centimeter or more. This can show, as we see here, both jaws, and you can see the diameter or the width can show completely the teeth and the vertical dimension as well. Something very important here, it's very important that during scanning of the patient for implant cases is to try to make the teeth separated from each other, not to be closing occlusion. Because when two metals are occluding together, they intensify the effect of each other. They make like a huge artifact, more than having one alone. In addition, also, it's easy to check the implant planning if they are separated from each other, because you can remove the jaw, which is not the jaw of interest, and check the implant planning. The last thing is the maxillofacial field of view, which is 13 centimeter by 15 or more. This can be used if this implant procedure is included with a bigger surgery, like an accident, for example, or something, and many maneuvers are going to be done. And the maxillofacial field of view is from the bottom of the chin, soft tissue menton, until the nasion up. Okay, second consideration that we should take care of is the metal artifacts. When you make a CBCT for a patient with no metals in his mouth, everything is going to be easy and clear like this. And all the machines, whether the cheaper ones, the expensive ones, the high quality or the low quality, will give like similar or very near quality to each other. The problem is when the patient has metals, you will have here multiple artifacts which obscure the visibility and makes some readings, especially in the bone quality, may be altered. So this is a reformatted panoramic cut showing this 3 implants. We can see some radiolucency between these 2 implants together in between. And this radiolucency is called the beam hardening artifact. So when we take a periapical radiograph for this same case, we can see here all the radiolucent areas are seeming to be healthy here. So the CBCT for cases with multiple metals or implants may give some false indications due to the streaks, the radiopaque streaks, and the dark bands which appear as an artifact superimposed on the image. So let's summarize our workflow that we should go through when having any implant case. First step, you should have an impression for the patient, whether manual impression and scan it on the scanner, or digital impression directly from the patient's mouth. And you should make a wax up, whether digital or analog, but here it's digital. And then you have the CBCT scanning, and it's preferable to correlate between the CBCT, which shows the bone, and the digital model that shows the surface structures, including the soft tissues. Then the CBCT and the model together with the wax up can be integrated. Then you can make your restoration based on the wax up. And the implant as a service is a prosthetic driven. It's not bone driven. We mean that we should look for the restoration first and then plan the implant based on the position of the restoration. So this is the prosthetic-driven implant planning, because it gives better performance and better biomechanics as well as aesthetic results. So what if we make the planning based on the bone only? Here, for example, here I have the CT scan, and then I don't have a wax up here. I just decided for myself to put the implants in this position. I find the bone here is good, so I decided to place the implants in this manner. So what we can see here is the implants is totally outside the restoration, and this will make a huge problem for us in the future on making the restoration. So here is the prosthetic-driven versus the bone-driven restoration. So implant, sorry. So here you must know how the restoration will look like, and then go through implant planning. And it's very important in your implant planning software that you have like a prosthetic simulation, that you can put imaginary wax up in order to imagine your treatment plan. Okay, thank you very much for your attendance. I hope that everything is going fine.